Will the NHI mean the outflow of all health workers and doctors in South Africa? All of that and more today with Henru Krüger from Solidarity about their latest NHI research. So, Henry, we can talk about expropriation without compensation. We can talk about prescribed assets. We can talk about pension funds. But today we're talking about national health insurance. Solidarity, of course, has recently come out with research on the national health insurance and possible implications for South Africa's healthcare sector. First of all, thank you very much for being with us today.
Thank you, Chris. What a pleasure.
So I thought we'd start off with a high-level discussion just about your research. It was 2 research documents. And of course, the viewers and listeners can go and check out everything, the PDFs and all of that on your website itself. But just start off with talking about maybe what's behind the research and just your high-level takeaways from those documents.
Yeah, thank you, Chris. The first research was an economic report. We did a costing on the NHI. So that's something that's absolutely lacking in the States outset of NHI. So I think with the first green paper, there was a costing, but it's never been adjusted up till this date. So our economic researcher, Theuns Dubisson, went and did thorough research. And according to what the government's figures are, we'll face a 32 billion budget deficit, if we would implement NHI. So what Solidarity Research Institute, Theuns Dubisson, did is he took the total healthcare budget, the current total healthcare budget, and he added on to that the 4 big hospital groupings figures onto that, just to be conservative about the spending in the private sector. And when you do that and you adjust it for inflation up until 2026, when the proposed date for implementation is, we'll face 112 billion rands deficit. So that's quite big. It's about the whole budget for the South African Police Service.
I was just going to say on the police service point, it's not like the police services, unfortunately, at the moment perform very well. So maybe we should cut out some of those budgets to allocate to healthcare, for example. I mean, that's an argument the FMF makes often. Why bail out state-owned enterprises like SAA, and why not allocate more money to things like healthcare and water provision? But just because you allocate money to a service or a system doesn't mean it's going to solve the problem. So, I mean, in your view and Solidarity's view, let's say that this money is found somewhere. Maybe the money is found in the pension funds. Having 500 billion, whatever, trillion rand, that's not going to solve what we consider the structural issues of the NHI, right?
No, most definitely not. So the big structural problems is endemic corruption and maladministration. And also, you don't have competent people appointed. And you also have a problem with the provinces. So the Minister of Health will have much times alluded to this, that the national minister has no control over the budgets of the provinces. And many a time in these provinces, the budget is spent on salaries and there's nothing left for service delivery. So that also is a big problem. But I also want to say that if something is broken and you don't have money to buy something new, you fix it. So in this instance, I think government will best serve the situation to fix what is there already, instead of now bringing in a new funding system.
I wanted to ask you just about this is a philosophical question, but also just a practical question around the importance of healthcare professionals. That's nurses, doctors, and everyone in between and everywhere else. I mean, a lot of your members, of course, are healthcare professionals. Just the importance of them and I mean, a lot of your research pointed to if the NHI is implemented, they indicated that they will leave the country. So from what I'm aware, and you can correct me if I'm wrong here, we currently have a shortage of healthcare workers. You can talk a bit about what's behind that, but also just the effect that the NHI would have on our already very strained resources, which I would argue has been exposed very much during COVID-19.
No, that's true. The importance of healthcare practitioners is that they are the people that's actually responsible to deliver healthcare. So without healthcare practitioners, there can be no healthcare services delivered or a healthcare system for that matter. So we did research. We did a survey in 2018. We repeated the survey in 2019, and now again, just last week, we released the newest survey, the 2021 survey. So the findings in that research paper, and that was done by Nicoline Veldhagen from Solidarity Research Institute. And any questions that viewers may have, they can direct to navorsing@solidariteit.co.za. So what the research showed is that 90% of healthcare practitioners are concerned about the NHI. And when I say healthcare practitioners, this was quite a representative survey. So we had all disciplines that participated, mainly nurses and doctors, but also specialists. So, and this was right across the provinces, and it was not only Solidarity members. So this was quite an extensive survey. So 90% of healthcare practitioners said that they were concerned about the NHI. So one could say, you know, that's an opinion and it's subjective. But the next one, you know, is very much important. And this is, you know, ask the healthcare practitioners what they think. They will tell you how they think. Nobody else can tell you. So you have to listen to them. So 85.3% of them foresee immigration being brought about if NHI would come into being. And then also for me, very interesting, and I was quite adamant, you know, that this question be posed, is that where do healthcare practitioners want to work? Because that's quite a contentious matter, and we know that the hospital groupings have made some submissions previously, even with the health market inquiry, you know, about employing doctors, because the person or the entity that actually employs the healthcare practitioners, they can deliver the service. So it's a very important asset, and it's a national asset that, you know, we have to actually handle with great concern. So 86.6% of the healthcare practitioners said themselves that they would want to work in private practice for themselves, making their own decisions. And I think that is quite laudable, because you want independent practitioners. You want them to apply their mind. You want them to work hard and put in the hours. You know, if our health care practitioners came back and said, I want an 8 to 5 job, I don't care for who I work, you know, I just want an easy job, then we would have been in trouble. So at least what I can say is we have excellent healthcare practitioners in this country that want to work hard, they want to put in the hours, but they want to make their own decisions. And that is why they have trained for so long. That's why they are professionals. And I was in a previous discussion with Dr. Khosi Lehlape from the Health Professions Council South Africa. And I was quite, you know, upset and complaining about the medical aids being prescriptive to doctors. And I remember quite well, he came out and said, as long as he has a say, you know, independence will be paramount, and that healthcare practitioners will be able to make independent, you know, decisions. So that for me is very much important. Then what's also concerning, 21% said that they will work with the state. 15% said that they were in support of the NHI. And then 79% foresee that the NHI will bring destabilization, that it will destabilize the healthcare sector. And then 78% indicated that they don't think that NHI is the solution. Then on the handling of the pandemic, Chris, you also said that this brought out the worst. Government argues that this is quite a good indication why NHI should be implemented. Healthcare practitioners said that only 10% of them were satisfied with the way in which the state handled the pandemic. 9%, even less, said that they were satisfied with the way that the government handled the vaccination rollout. And then 10% said, that the pandemic showed that the government would be able to deliver universal health care. So that's the summary, Chris. It's quite shocking. And we have to listen to our healthcare practitioners, and surely at Solidarity, that's exactly what we do.
Yeah, I don't think we should take it as a given that people will just keep on going into healthcare. I mean, if you disincentivize them through policies such as the NHI, why wouldn't they either go into a different sector, a different path, or just leave the country? I mean, people want to work, regardless of the job you do, you want to work in some sort of good environment where you have independence, as you say, some sort of ability to take actions. You can work well with your management team, your boss. Imagine when the NHI comes in, if there's an issue and you try and report it up the chain, it either just gets lost, or if there's corruption, I mean, maybe that'll be encouraged. So you'll be thrown out if you report that kind of thing. So, I mean, obviously, I'm glad that your research reinforces what we've been saying for many years, both at the FMF, at Solidarity, I think other organizations, just about how centralizing the management of all healthcare isn't going to fix any of the problems in the public or private healthcare sectors. So I think that's very important, regardless of whether one strongly ideologically thinks there should be universal healthcare or not. There are better ways to reach that end goal for all South Africans versus a centralized state-managed system. So my next question to you is just, did your research, did it also cover people in the public sector, for example? So someone in civil service, that kind of thing. We know South Africa's civil service is very big. So I just wanted to ask you about that question and if there's any sort of difference in the responses then.
No, definitely the public sector was also approached, but the biggest concern would be in private practice, and that's where our main focus is. We have a guild for nurse practitioners as well, so a lot of the nurses participated. So those would be mainly employed in hospitals, maybe private hospitals, but also state hospitals. So I think even, if you work for the state currently, you will see the absolute shortages of personnel. It's quite shocking. We have one of the worst nurse-to-patient ratios in the world. We have one of the lowest doctor-to-patient ratios in the world. And the main reason for that is that we don't train enough. And we have to lay that squarely at the door of the government, because they're in control of training, our practitioners. They do not allow training in the private sector. And every 6 months when we have these student doctors that have to be placed, it's a huge issue. We again had this just a month ago, where about 300 student doctors were not placed. And, the state must make provision, for them to be trained. If they can't do that, they must allow the private sector to actually train. So many of the nurses, and we've discussed this with the South African Nursing Council, and I have seen a response from them, is actually practicing outside of their scope of practice. So there's too little nurses, so you get an assistant nurse doing a registered nurse work. and that's problematic, in a workplace environment with workplace discipline. If you work outside of your scope of practice, you'll get in trouble with South African Nursing Council. Your professional indemnity insurance won't cover you, and you'll get in trouble with the patient as well. So we have to be aware of the shortages, and the shortages in the state sector is a big problem. And the reason for this is quite a few problems and reasons. But like we've mentioned, the big problems is the maladministration, the incompetence, the corruption, the security issues, the medicine stockouts. There's no water, there's not electricity, there's a host of problems in the public sector. And that is the reason why healthcare practitioners do not work, for instance, in state clinics. And you'll get this criticizing that doctors are just focused on money, and when they don't get the money, they leave the country. That's not true. Me and my colleague just had a look at the government pay scales, the salary scales yesterday. Government pay is good. They pay too much, actually. It's quite extraordinary what you can earn in the state sector. But the other problems, facing you have to relocate your family to a distant area. There's no schools. You can't do your professional training. It's really not conducive to good healthcare to go and work in those areas. And that's now, why the government has now published the regulations, the certificate of need regulations to actually implement section 36 to 40 of the National Health Act. And we can maybe have a look at that process. But what leads to that is the government's inability to provide healthcare services where they should. They haven't been able to attract healthcare practitioners, although they had the budget. I know for a fact that there was budget all these years to recruit healthcare practitioners. I myself and a lot of my colleagues, we tried to contract with the state. It was never successful. And now, they bring out the stick. There's not enough carrots, and now they bring out the stick. So that's very unfortunate.
I wanted to just get your explanation on certificates of need, because that's one thing I think that's quite big in the shortage aspect. So I wanted you to just explain a bit what that is and how one either amends it or appeals it or deals with that issue.
Yeah, so a certificate of need, to just put it plainly, you determine where the need is, and then you actually direct the healthcare services towards that need. And you have to marry the two, you have to overlap them. So if you look at the medical schemes industry, you've got a good spread of healthcare practitioners to service medical scheme members. And the reason for that is doctors want to work for medical aids. They know that they're guaranteed to get payment, and they actually locate to where these medical schemes members are located. So it's a good fit. Why doesn't it work in the state sector? We've mentioned the problems. So what the certificate of need is, it's section 36 to 40 of the National Health Act. It's never been enacted because in 2003 under President Mbeki, it was said it was intended to implement it, and healthcare practitioners took to the streets. So they actually did a march and they striked, and it was not implemented. Then in 2015 under President Zuma, it was enacted, and it got stayed in the Constitutional Court. So the Constitutional Court found it to be irrational because the regulations weren't published. So healthcare practitioners had to apply for a certificate of need, but they didn't know how because it was not stipulated. So the state legal advisors advised the president to approach the Constitutional Court, and it was stayed. So now, under President Ramaphosa, the regulations have now been published. So you can't refer to the regulations without going back to the stipulations of Section 36 to 40 of the National Health Act. And this is exactly what we've done in the Guild for Healthcare Practitioners. We approached through our legal representatives as senior counsel advocate, and she gave us an opinion on, the matters in the regulations read together with Section 36 to 40. And so it's quite extensive. So it covers all healthcare establishments, healthcare agencies, healthcare services, and then also healthcare personnel. So it's all the allied health professionals, it's the healthcare Health Professions Council professionals, it's the Pharmacy Council, it's the South African Nursing Council. It basically includes everybody except maybe chiropractitioners, the Chinese medicines, and community healthcare workers. So every one of those practitioners must now apply for a certificate of need in order to practice. And the requirements for obtaining the certificate of need is also quite prescriptive. And the person that's going to be in charge of this is the Director General of Health. And at this stage, we're seeing this whole corruption matter with the digital vibes. And we've now only seen recently, even the Director General is now up for scrutiny. So, this can lead to a very unfortunate situation. And I found this in the US, that the certificate of need gives the opportunity to corruption and to misuse. So you can absolutely abuse that power. And our contention in this matter as well is that the discretion that is allowed to the Director General is so wide, it's unfettered, it's vague, and it amounts to the DG to have to look at the potential benefit of issuing a certificate of need. Now, Chris, I don't know, you and the viewers, you can tell me what is potential benefits. It's quite, vague. It's so wide, it's going to be a problem. And then also, it's been criminalized. So if you don't have the certificate of need, you face a jail sentence of 5 years or even a fine and imprisonment. So this is a stick, eh? This is how you handle your healthcare practitioners in this country. You want to threaten them with imprisonment to go and work where you see it fit for them to be working. So that is quite unfortunate. It's unacceptable. And then also our contention is that these regulations is irrational because we've seen in the US that the actual intention of bringing into being a certificate of need doesn't serve the purpose. So in the first instance, it actually restricted access to healthcare. In the second instance, it made healthcare services more expensive. And in the third instance, it actually lowered the quality. And then I also mentioned, the possibility for corruption and misuse. So it's irrational. Why would you want to pass regulations that actually works against what you want to achieve? Then also it's unconstitutional in our opinion because Section 22, your freedom to actually choose a profession, that's severely restricted. Section 25(1), you'll be arbitrarily, be taken, your property will be arbitrarily taken away from you. Then Section 25(2) is expropriation without compensation. And why we say that is the Director General will have control over medical equipment and diagnostic equipment. So it may even be that they say you have to let the state use your equipment, and there's no compensation mechanism built into the regulations. Then Section 27, this is the argument: you have to actually give access to healthcare. This will actually restrict access to healthcare, especially if you withdraw a certificate of need, because there's no distinction made between existing practices and new practices in the regulation. So if there's an existing practice and you withdraw that certificate, or you don't grant the certificate, all those patients will be left without healthcare. So that's also unconstitutional. And then even Section 36(2), that actually deals with the certificate of need, puts no obligation on the Director General to consider constitutional rights or to consider the practitioner's rights. So it just gives her the rights, but there's no obligation. And we know in law that every right comes with obligation. So, and then I've touched on the vagueness, and then also the provinces. So this is going to take away the decision-making of the provinces, and that, of course, is unconstitutional, because the Constitution stipulates that the provinces have the say over provincial matters. So that, in short, Chris, that's the problems. And we've actually advised or commented that the minister has to completely redraft these regulations. And we've recently written a letter to the president, the minister, the DG, all the MECs of health of all the provinces, all the regulators, and even some associations. And we've actually demanded that the president withdraw the regulations and given an indication that he will not implement Section 36 to 40 of the National Healthcare or the National Health Act, because it is going to be unconstitutional, and he cannot pass legislation before determining whether it's constitutional or not. So the state legal advisors must have a look at this. They must first determine whether it's constitutional or not before passing it. So that's where we are at, and it's quite unfortunate.
Well, don't worry about the constitutional issue. If we want to enact something that's unconstitutional, we just amend the Constitution. So
yes, the Ninth Amendment.
The path forward.
Where are we at now? We're now at the Eighth Amendment of the Constitution already.
Yeah, exactly. Before I get on to my other questions, we've got a few questions from those of us with here live. And thank you all again for watching with us and listening to Henru unpack Solidarity's research. So our first question is from Jesse. Thank you very much, Jesse. So he says when he was younger, they had a family doctor that used to help us even when we didn't have money. Why is healthcare so expensive, and what makes it so expensive? I know that's a broad question, obviously, and you've touched on certificates of need, other regulations and issues like that. Is there anything else that you want to highlight? And maybe you can just touch on the health market inquiry, for example, which we think, I mean, it would require actual hard work being done, but it's a much better path than just taking the shortcut and band-aid of national health insurance.
Yeah. So the question of healthcare getting too expensive is a real concern, and it's a real problem. So that's why we actually met with the Minister of Health, the previous Minister of Health, and he wanted to fix prices in the private sector. And he was quite adamant about it. Previously, we had discussions between the previous RAMS, and now it's the Council for Medical Schemes and SAMA that represented the practitioners. And there was negotiations, and the tariffs were determined, the National Health Reference Price List. And a few factors were taken into consideration in determining those prices. And then the Competitions Commission actually put a stop to that, issued fines. And then the minister said, no, but he wants to fix prices. And the Competition Commission again said, you're not allowed to fix prices. So we had this whole health market inquiry that actually focused on competition in the healthcare sector, because that's how you bring prices down when there's competition. So there's no perfect competition at this stage in the private sector. So you have a few big administrators, you have a few big hospitals. Your family practitioner is not a problem. I can quite honestly say that. We actually advocate for family medicine and a quite more preventative way of practicing medicine. So where it gets expensive is in the tertiary sector, when you have to be admitted to a hospital and be treated by a specialist. And when you speak to people in medical aids, medical schemes that's involved with setting up the benefits, that's where the real costs are. So your day-to-day, your general practitioners, your family practitioners, not the real expensive part. And the other problem is with medical aids and schemes is they have to provide for a prescribed minimum benefits. So that's also something that the state pushed down onto the private sector. So those are prescribed minimum benefits. It's quite all the critical stuff, the real serious conditions, and that's quite expensive. So they have to provide for that. And they have to build that into their benefit design. So even though you don't use it on a yearly basis, they have to provide for that. So that's how the insurance industry works. So the health market inquiry was quite a long process. Chris, we had a few years of that. Everybody was involved except the public sector. The minister quite specifically excluded the public sector, so that's quite unfortunate. But the recommendations that came out of the health market inquiry was quite good. One of them was that we should have a supply side regulator. So in the end, everybody was saying that it's supplier-induced demand that's actually pushing up the prices. So it's over-servicing and, doctors telling patients to do certain procedures, and that's what's making it so expensive. We're not quite, in agreement with that, but in the end, the proposal was there for a supply-side regulator. We're quite supportive of that, because then we can again look at pricing, at what pushes up prices, what has to be factored into tariffs, and we can actually have a good idea how to regulate that. The other recommendation was the organization for the monitoring and reporting of outcomes, because, you can pay a lot for medical services, but you don't get the outcomes that you want. And that's the US system. Quite expensive, but real bad outcomes. So you have to look at pricing and you have to look at quality at the outcome, because you don't want to make something so inexpensive, but it's not worth the quality that you pay for. So those two recommendations coming out of the health market inquiry, we can quite definitely look at. But again, Dr. Ambam Pillay, the Director General, said he's not going to spend money on the supply side regulator and the Organization for Monitoring and Reporting of Outcomes. He'll much rather spend that money on NHI, which is not a clinical system. It's got nothing to do with healthcare. It's just a funding system, NHI. It's not going to address any healthcare issues. It's just going to push money into a fund.
Our next question from... Sorry, you're getting an echo on your side. It might be on my side, but it sounds fine now. Just from Tato. Thank you, Tato. So, of course, NHI will be a disaster for the country. Ideally, healthcare should be privatized. Government can introduce something like a voucher system to give to people who can't afford private healthcare. What do you think of vouchers as a possible solution, Henru? Do you think that's a good idea? I mean, some people will say, how is government going to fund vouchers, that kind of thing. So just what do you think of the voucher idea?
Yeah, thank you, Tata. You're my hero for bringing that up. Now, I'm quite supportive of vouchers. It's working quite well in other countries, and especially in underdeveloped countries, because you can actually structure a voucher very well. You can put in the healthcare services on that voucher that you want to, and you actually incentivize somebody to utilize healthcare services where you want them to utilize that. So if you've got somebody with high blood pressure, you give them a voucher and you actually incentivize them to go to the practitioner to get sorted out before, it amounts to a heart attack or a stroke. So how you fund vouchers is government can levy a contribution and then give it back to the taxpayer by way of a voucher. So then you have the choice to actually go and present that voucher at the healthcare practitioner of your choice or the establishment or the specialist that you need to visit. And then included in that voucher, will be the healthcare services that have to be delivered. So the chances of over-servicing even is also not there because, you can hard code which services has to be delivered and you can put requirements into place when you will redeem this voucher. As soon as you get proof that this healthcare service has been delivered, then you pay the practitioner. You redeem the voucher. So we can have a whole discussion on that, Chris. It's quite interesting, and I think the World Bank has also, gave a guidance document that's quite, it gives you a very good indication on how you have to implement it and how you can administer it. And we actually included that in my previous position when we made our NHI proposals and comments. We actually included that in our recommendations.
Yeah, I think vouchers is definitely also one of the things the FMF has advocated for many years, and we think it's, in a way, it just puts more control and power in the hands of the citizen and also the healthcare practitioners. Another question is around traditional medicine. So this is from Lars. Thank you, Lars. Does the NHI include traditional healers? They handle many small complaints like flu and that kind of thing. It takes massive strain off the medical industry, but we don't acknowledge that. What do you think of that sort of point? Do you think Lars has a point here around how NHI can possibly affect traditional medicine in South Africa, which I think we often forget about, but is a very big part of people's lives?
No, traditional healers are for certain in the mix, and they are regulated now. So the question, does NHI include traditional healers? It's a good question because we haven't got much about healthcare in the NHI bill. Like I said, it's just a bunch of committees that have to be set up, and those will be determined by way of regulations that we haven't seen, that haven't been published. So it's just a framework. And at this stage, the only thing that I am aware of and that we have been told is that it will focus on primary care. So if you look at it that way, most definitely traditional healers will be in that primary care layer that will be implemented.
A question I had for you was just around, and you touched on this a bit earlier, but the whole digital vibes saga. So I feel like, and this is the case not just in healthcare, but many things in life and in society and government, but for a lot of people, they place their trust and their faith in certain personalities and individuals. And it's not just the case of the current ruling party. I think we would argue, no matter which party is in power, we shouldn't have a system like the NHI, which incentivizes and encourages more corruption like we've seen through digital vibes. And last year with the pandemic, when we saw massive PPE looting, contracts in Gauteng, I think the Gauteng Department of Health, the amount of money they spent on sanitizing schools in ways which have now been proven is not effective to help eliminating COVID if it was present in the schools in the first place. So just your thoughts on what we can learn from digital vibes. I mean, we obviously, we're waiting, the whole of South Africa is waiting for the Special Investigative Unit report. I believe President Ramaphosa is still studying it. Maybe he's shocked at the contents, and that's why it's taking so long for him to actually release it publicly. But what do you think of digital vibes and what it tells us about, again, why we shouldn't go down the NHI route?
Yeah, so I would like to quote Prof. Alex van der Heever here. He actually mentions the SARS model, which he calls the South African Revenue Services model, where you actually centralize all the power in the minister of any of these portfolios, in this instance, the Minister of Health, and absolute power absolutely corrupts. So that's very bad. If you have a talk to an auditor, or anybody that's involved in the delegation of authority sort of structures, and you don't centralize everything into one person, like with now the certificate of need, centralizing everything into the Director General. That's a recipe for disaster. And then you allow that person to actually appoint committees. So he's also in control of all these committees. So even when you now delegate authority, you still have a say in the composition of those committees. And then when budget comes into play, you also have a lot of say on how the budget gets spent. So it's a model that's set up to create the opportunity for this sort of corruption to occur. And it's a problem. I've read Prof. Alex van der Heever's comments on the Social Security Green Paper. And he says that's quite different from the NHI model, because this fund will be managed as a public fund, but under scrutiny, not of the Auditor General, but really by the public. So that can be a sort of a solution. And then also, then you can look at the 12% contribution that you make, not as a tax, but as a contribution that's really going to go where it has to go and be allocated and used like it should be. And I think now we in Solidarity, and even AfriForum has now brought out a tax manifesto where it actually says we just want to have a say about our tax money. So it's quite like SCOPA, you have to have a sight of these accounts, and you have to have a sight of the budget, how it is spent, and you have to have a say. And if we can get that right, then maybe we can say, I will voluntarily contribute to this fund because I'm quite certain where this money will be going, and the quality of services that will be brought with that, and the competence of the people that's going to be in charge of this.
I think that's a very important point. It shouldn't continue to be the case where it's just assumed that citizens just are happy with everything the government does with their tax money. I think given both how badly tax money has been used the last decade, the looting, the corruption, but also just there's that social contract idea, and it should cut both ways. It can't just be one way. I think many people would, and as you say, people would pay into it if they actually knew where it was going, what it was used for. People want to look after themselves, their families, their communities, but then let them have a say in it.
Yeah, so we have a saying in Solidarity, ons sal self. So we believe in more community, less state. But also, I enjoyed quite much what Prof. Alex van der Heever said. Let's get the discussions going. Let's have real, town hall discussions. Let's have robust discussions, not this one-way sort of government, publishes regulation and they want to force us into a way, and then we have to comment, and they can look at our comments, but not really look at our comments, and in any case do what they wanted to do. This is not conducive to, like you say, a social contract. And we have to have those discussions, and we're willing to have them. It's, we have to work towards solutions, and we have a lot of solutions to put on the table. We do quite a lot of research, and, we have quite some people employed that know what they are doing. And we have brilliant minds in this country. I mean, we've seen with the health market inquiry. And Chris, I just want to mention a few years ago, I was part of the Ideal Clinic Realization Program. It was actually, an initiative of President Zuma. It was based on the Malaysian government approach of big results fast. All of the big minds were there. There were consulting agencies. I had a team leader from Mexico, and there were a lot of good stuff coming from that. I think the problem was in the end, Parliament said that it was too expensive. It was not, they were not able to fund it. But let's relook those solutions. Let's put all the solutions on the table. In the medical schemes industry, you have brilliant minds. You have actuaries. There's more actuaries in Discovery than I think in the whole of Africa. And, they've come up with some brilliant models. I'm thinking about the risk equalization fund between medical aids, depending on their age profiling, the cross-subsidization across benefit options within a medical scheme, relooking the solvency requirements for medical schemes, the low-cost benefit options that we put on the table by medical aids. We can really broaden the access to medical aids. We can fix the private healthcare system. We can fix the state clinics. There's a whole plan. It was a 3-feet plan. We had to plan it down to 3 feet, meaning that we can implement that on root level. That's been done. I've got the report on my computer. I'm just not allowed to share it because I've signed, an agreement not to. But let's put all the solutions on the table. Let's debate about them, and let's start doing and fixing instead of bringing out the stick and threatening.
I remember when myself and Mike Setas, the chairman of the FMF's Health Policy Unit, when we were presenting to the Parliamentary Committee on Health on the NHI last month or 2 months ago, a lot of the questions after our presentations focused on, but quote unquote, what about the poor? What about social solidarity? What about, people who can't afford healthcare? As though the idea is centralizing the management of all healthcare is going to increase access to healthcare for poor South Africans. And I think the solutions that Solidarity especially is proposing and advocating for, yes, we want to get to that endpoint, but you don't do that through exposing healthcare services to factors which increase the costs of those services in the first place, right?
Yeah. Now, in the Solidarity movement, we've actually written a whole community care plan. So we can assist communities to implement healthcare at the lowest level. We've had discussions. I had good teachers in, the heads of family medicines that actually had a look at community-oriented primary care. And I actually went to Soweto, to the best clinic in the country, to go and look at how they implement that. So there's solutions. We have those solutions. We can most definitely have a look at it. I know Treasury has costed a model, a capitation model that's based on, community-oriented primary care. So it's taking healthcare to the community, to the traditional healers, to the family medicine practitioners, not disease management and, focusing on ambulatory care, hospice-centric care. It has to be patient-centered. You have to appoint a coordinator of care, which can be your family practitioner, but you have to practice with science. That's what the professor taught me. Practice with science. Use an interdisciplinary team. Don't just focus on one discipline. Get all the disciplines involved, and do preventative care. A lot of our disease profiles in this country is non-communicable diseases. That's what's killing us. That's lifestyle diseases. You can prevent those with a good dietary plan, with exercise, with keeping healthy, just have a healthy lifestyle. So we can have those discussions. It's not going to come from above. It has to come from the community, and you have to take healthcare to the communities, to the homes.
Don't worry about the health life choices, because I see there's talk of doubling the sugar tax now. So don't worry, government will tell us how to live healthily. So we shouldn't be too concerned about that. Henru, just as we wrap up in the last few minutes, I wanted to give you just a bit of space to talk about Solidarity's other work and other campaigns. I mean, the NHI is obviously very important, and we really appreciate, and I think South Africans appreciate the work that Solidarity is doing. But other campaigns, things coming up that you wanted to highlight that Solidarity is working on, that and that you want people to engage with you on?
Yeah, Chris, I think the pandemic has been very hard on all of us. So we're actually planning a ceremony for our nurse practitioners. We really want to honor them for the sacrifices that they've made. Some of our nurse practitioners paid the highest price. We will never forget them. They will always be on our minds. And please look out for that function that we are going to have. Participate in nominating and voting for your specific nurse practitioner that made a difference in your life. And yes, let's honor our nurses because we have a nurse-based system in this country. It's mainly run by nurses, and most of the times people, think they're angels, and they are, but they're also highly skilled professionals, and they're in a very scarce supply. So most of the times, they work outside of their scope of practice. They work under difficult circumstances, and they don't get treated as nice as they always have to be treated. So many a times they respond in being rude, but they're under severe stress. So we're just going to honor them and have a ceremony for them. And we ask everybody to please support and participate in that.
Yeah, I think that's amazing work, and it's very important that we don't forget what has happened in the last year. I mean, we can all talk about the vaccine mandates, we can talk about vaccines themselves and that kind of thing. We shouldn't forget the people who have actually worked in hospitals and the pressure that they've been under. So I greatly admire that initiative. But yeah, Henru, on that note, we want to thank you for your time today for talking about Solidarity's NHI research. I found it very useful and interesting, and I hope that the listeners use this information to both inform their own comments and discussions around the NHI. So thank you.
Thank you, Chris, for the opportunity. Really appreciate it.
To the viewers and listeners, thanks once again for joining us for another live episode. We hope that you found it useful. Please like the video before you leave and also subscribe to our YouTube channel. If you haven't yet, look forward to more episodes in the coming weeks. We look forward to engaging with you. If you need any other information from the FMF, please go to our website, www.freemarketfoundation.com. Until next time, stay safe out there and take care. Bye-bye.